Thank you. I want to get into the topic of access as it relates to home health. Earlier this year, the Medicare Payment Advisory Committee reported to Congress that almost all beneficiaries have access to home health services based on data indicating that 98% of beneficiaries live in zip codes served by 2 or more home health agencies. So they're kind of claiming success through that, at least, particular analysis. However, simply living near a healthcare facility does not necessarily guarantee a patient's access to services. Dr. Grabowski, could you speak to the challenge of access in home health and why living in proximity to an agency is not necessarily an ideal indicator of access in this context?
Yeah, I love the way that Dr. Moreau's framed it earlier. It's necessary that you have a home health agency in your zip code, but it's not sufficient. And because you have one in the zip code doesn't mean they're regularly accepting new patients. It doesn't mean they're delivering timely visits. So it's great that we have this strong supply of home health agencies around the country, but it's not always clear that supply alone is an indicator that individuals have strong access. Thanks.
So they're scoring this as a 98, which usually is an A on most tests, but suggests perhaps there's a problem here.
I can't speak for MedPAC and why they do that, but I think the issue is data. We just don't have the kind of data on timely visits, whether they're accepting new patients, and so the supply is a nice proxy for access, but it doesn't tell the whole story.
Yeah, well, Dr. Grabowski mentioned you, Dr. Moreau's. I think you probably have some thoughts on this as well.
Yes, thank you. So as we mentioned, there is quite a gap between referrals to home health and actually admission to home health. And Ms. Edwards spoke to this point as well. I mentioned that fewer than 60% of beneficiaries with a discharge order from home health coming from the hospital actually wind up admitted to a home health agency and get that care. So I am 100% a believer that the number of home health agencies that serve a zip code is not going to give an accurate picture. As Ms. Edwards also said, I'll call out as well her personal experience in this with her home health agency. We hear it from our research too, that many home health agencies they don't have the capacity to accept every referral and every admission that comes their way.
So if may not be the ideal proxy, is any thoughts around what might be a better proxy here as we try to evaluate access?
Yes, we need to compare actual rates of use of home health, which we do see disparities, particularly in the most rural communities. And we also need to look at refusals, referrals that are refused. We need to talk to the home health agencies to see how much they're being asked to provide services and whether or not they do that. The one challenge in that, though, is there are communities where they stop even referring to home health because they know their patients are not going to be accepted. So there will still be a gap in measurement, but that's a start to moving towards a better.
Well, it's helpful. There'll never be a perfect analysis, but perhaps better as possible. So we start to look at this to get a more accurate picture of reality. Since 2001, Medicare has intermittently provided an add-on payment for home health agencies serving rural communities through varying reimbursement percentage increases. The most recent rural add-on payment was a 1% increase to home health agencies providing services in low population density areas for the duration of 2023. Dr. Moreau's, we're from the kind of the same side of the country out there at UW. Could you share your perspective on the value of this add-on payment and how it affects the service delivery and accessibility of home health for rural patients in Medicare?
Thank you, Senator Daines. I'd be happy to comment on that. We have found in our research, and research from other universities have actually found that the rural add-on payment has great potential to both increase access to care as well as provide the services that they need to provide, reducing hospitalizations. So the decrease and then sunsetting of the rural add-on payment is of great concern. So 1%, our research shows that that's probably not enough to make a difference for home health agencies to be able to serve more rural beneficiaries and to provide the services once they're being admitted to the service. So I think targeting, I will say research also really supports targeting. Rural is not homogeneous. You know this. Anyone that lives in a rural state knows this. Not every rural county is the same. So we also need to make sure that those rural add-on payments are targeted towards those beneficiaries that are truly not going to receive care otherwise.
Lastly, Ms. Edwards, I mentioned in my opening remarks some of the difficulties providers face when operating in rural and less populated service areas. Could you share with us some of the challenges you're experiencing at Mary Lanning and maybe perhaps the best practice you put in place that might help address these challenges?
Yes, I would be happy to. Thank you, Senator Daines. Our biggest challenge we're the rural, and we still are rural, just covering one county. When we covered those 13 counties previously, that was 42,000 Medicare beneficiaries, not including the pediatric patient population that we serve. We are one of the only home health agencies in our region that take pediatric patients, so that impacts all patients of all ages. Now that we've decreased, there's about 7,000 Medicare beneficiaries just in Adams County, so that impacts a lot of the beneficiaries because some of those counties are still not covered. I would say best practice, the tenured staff we have, they love what they do. They're focused on high-quality care, and we try to accept every referral we possibly can within our area. If we're contracted with their payer type, that's always a challenge as well.
Thank you.
Senator Blackburn.
Thank you, Mr. Chairman, and thank you to our witnesses for being here today. This is an issue I've worked on since I was in the state